mature white cataracts, and we have the superstar from Bombay, management of subluxated heart cataracts, which is a very, very difficult thing to do. And Dr. Nitin Balakrishnan, Saideep Eye Clinic, and Crystal Vision Laser Center in Mumbai. And again, I'll come back for the management of heart cataract using the femto or the flax technology. So let's talk about the small pupil heart cataracts. So you are in double trouble because you have a small pupil as well as a hard brown cataract as well. These are the various scenarios wherein you can have. It's very common, not uncommon in a country like India. So what is the biggest problem? The biggest problem is the hard brown cataract, the posterior polar cataract, subluxated, or the pseudoexfoliation. The biggest problem is the small pupil. Why? Because in small pupil you are not able to see well, and that is the reason why you are not able to operate well, and that's the reason for all the complications as well. So because the pupil is small, and that's so you need to make sure that the pupil is well dilated, especially when you are dealing with cataracts like the supra hard cataracts. We call it the cataract or rubra or the cataract or Niagara. Okay, and small pupils can be because of long-term use of miotics, pseudoexfoliation, prior iritis with cyanic A, trauma, diabetes, and improper mydriatic application as well. It's also associated with advanced age, advanced nuclear sclerosis. Use of anti-prostate agents, alpha and tamsulosin, can produce small pupil. Please understand, go through the history is very, very important. Okay, ask for the patient because many patients, even physicians, may not know that tamsulosin can cause a problem like IFIS, which can lead to a severe problem. There is the intraoperative floppy iris associated with the use of alpha-1 antagonist, tamsulosin or Urimax, lack of tone of the dilated muscles of the iris, a triad of intraoperative signs, iris billowing and floppiness, iris prolapse, progressive miosis of the pupil. So, as you are operating, initially the pupil may be 6 millimeter, progressively it will become 3 millimeter, and you are in trouble at that time. You can stop miotics 48 hours prior to the surgery, long acting, but all these may not work as well. And you need to use what is called the soft cell technique, which has been developed, popularized by Steve Arshinoff, wherein you put viscoat, that is a dispersive viscoelastic elastic, which coats the endothelium, and then you put hyaluron underneath that so that it expands the pupil and also protects the endothelium, especially in brown cataracts. Pupil expanding devices like iris hooks or the rings you can use. And these are some of these challenging situations. You can see here, many of these cases, you can say, sometimes they have cyanic A. You can open up the cyanic A. And even if you don't have access to any of these rings, you can even stretch the pupil. Only thing is the problem is stretching don't stretch the pupil in the axis of the incision, because the stretching can cause permanent damage and atony of the sphincter as well. You can see here that many of these cases of complicated cataracts, small pupils, there is a small membrane which is not visible on the slit lamp but is visible under the microscope. Once you remove the membrane, you can see how the pupil starts dilating as well. So the fibrous pupillary membrane, you can see here, this is a complicated cataract, post silicone oil vitrectomy, and you can see here how the membrane, once you remove the membrane, you can use small forceps or scissors or vitreous scissors to cut these membranes, go through the side ports, and use good viscoelastic, and you can see fairly good dilatation as well. So pupil stretching can be done. You can use iris hooks, pupil expansion, whatever you are comfortable. Intracameral phenocaine is available, phenocaine plus is available, the ultra is available. So many companies, I don't have any financial interest. It's a combination of preservative-free tropicamide, phenylephrine, and proparacaine as well. So that can also dilate the pupil to a certain extent, but many of these small pupils are rigid, so very difficult. You can see here how I'm putting the patient to pseudoexfoliation, a dense brown cataract as well. When you're putting the iris hooks, it's a very easy technique. Only thing is you make sure that you put the stab incision at the limbus and not in the cornea. Okay, and make sure that you elevate the iris, putting some viscoelastic underneath the iris, and so that it's easier for you to put. If you put it in the cornea incisions, the whole iris will start tenting up, and this can be a major issue. and going in and coming out of the iris, coming out of the pupil, the main incision with the phaco probe, the iris can start coming out. You can see how easy it is, because once you do that, and you can stain the anterior capsule in a brown cataract, it's always better to stain, because you know exactly where your rhexis margin is, and when you're doing the chopping. So just to show you another patient, the pseudo exfoliation, you can put adrenaline in the BSS, but consider patient with a mature cataract, very hard cataract. Blurex is very important, not only in mature cataracts, but even in the hard brown cataracts, because you know exactly where your rhexis margin is. Put the Blurex and keep the Blurex. Sometimes you can put air so that the Blurex stains, the trypan blue stains the anterior capsule uniformly. And once you go around, you can see how I'm trying to do the rhexis slightly bigger than the size of the pupil. For me, the size of the rhexis matters, and that is very important, because when the pupil progressively becomes smaller, you know exactly where your size of the rhexis, where your rhexis margin is. So in this case, I'm just going ahead and trying to do, because the pupil is fairly mid dilated, and going ahead and doing a trench there. I'm doing what is called a vertical chop. There is no this thing for horizontal chop in this, because horizontal chop, what you do is go underneath with the blunt chop, underneath the capsular recess, come from the periphery. The vertical chop, use a sharp chopper, you can see here, chopping right in front of the rhexis margin. So in small pupils, it's always better when you're using a vertical chop, because you know exactly, it's not a blind technique. You visualize each and every step there, and go ahead and you can see, chop it into multiple pieces, making sure that the crack is going all the way into the posterior nuclear plate, which is very, very leathery in these brown black cataracts. So that is again very important. Once you do that, make it into as smaller pieces as possible. Now and then put viscoat into the anterior chamber, and I don't have any financial interest, and but viscoat works very well, because it prevents corneal endothelial damage. You can have clear corneas. You can see how the entire surgery goes on, and you are making sure that you are right there, not near the rhexis margin, because I don't want the the iris to come into the port. So you reduce your parameters. Normally, if you are using about 500, use about 300, and if you are using a peristaltic machine, if you are using an aspiration flow rate of about 50 or 60, you reduce it to about 25 or 30, because you don't want that non-target tissues like the iris and the posterior capsule to come forward as well. So just to show you this Maligan ring, the different choices, different things available. Maligan ring is available, the Gupta ring is available, BX ring is available. The only thing is, the Maligan ring is like a safety pin. You can see here, it's a there's an injector system. Now the new Maligan ring, the 2.0 version, goes through a very small incision as well. Putting the Maligan ring is not a very major thing, but removing it is really a challenge. You need to be a little careful about that. You can see here beautifully, there is there is a dilatation of the pupil. You can see her underlying hard brown cataract, and rhexis, making sure that the rhexis is as big as possible in a brown cataract like this. As big means you don't want to be more than 5.5 millimeter, or at least 5.25 or something like that, and because you want that space in front of the so for you to do the horizontal chop, because these cataracts are very, very big cataracts. They're very large cataracts. The diameter of the cataracts, the thickness of the lens is as big as 5 to 5.5 millimeter, and the nucleus and more nucleus, it's about 8 millimeter or even 10 millimeter for that matter, the diameter. So removing of the Maligan ring is very important. The advantage of the Maligan ring is that the pupil size is maintained very well, and the pupil anatomy is maintained very well. And even in a multifocal lens, you can go to, sometimes iris hooks can damage, you can have sphincter damage. You can see the pupil is exactly round. Or you can put a this thing, or BX ring, which works very well as well. Only thing is, I find the BX ring is a little fragile. So you can go through the main port, you can remove it through the side port. In a patient with the IFIS, it doesn't push the iris, because it's not very resilient like the Maligan ring or the iris hooks. Doesn't push the iris as much back as you want to, and that is one of the major problems with the this thing. But otherwise, it works wonderfully well. You need to have a good pupil of about 5.5 millimeter hexagonal, and that's why it's called BX, and it works very well. Again, a patient, as you can see, a complicated cataract with posterior synechiae and going around and releasing the synechiae is very important. So once you, because it is a hard brown cataract, you can't manage. Obviously, this video was taken long time back. Once you remove the synechiae all around, you can see here. Sometimes the entire iris is plastered. I'm just doing this iris stretch. The iris stretch sometimes you need to do, and if you don't have access to any of this, but I would not recommend this. But this patient, you can see here, before the advent of the iris hooks or the Mulligan ring, we are able to manage with this. You can see here, I'm making a deep trench there, and you can do what is called the stop and chop. So once you do the stop and chop, you know exactly, and try to stay always in the center and reduce the parameters as I told you. Again, another patient, you can see here, this is a floppy iris. A patient, this is a patient on tamsulosin. So these are patients right in the beginning of the surgery. You decide, okay, in the middle, if you want to put an iris hook, it's so difficult. If you want to put a Mulligan ring, it's so difficult after the capsular excess. So once in the beginning of the surgery itself, you decide, okay, this patient, hard cataract, small pupil, on tamsulosin, the pupil is going to come down further on you, and definitely if it is going to be 4 millimeter at the beginning, it will be 2 millimeter by the time you are halfway through the surgery. So once you put the iris, you can see how comfortable it is. So that is the main idea. So visualization is very important. The reason why I tell all my postgraduates and residents is that you need, because you are not good in your microscope, you are not able to focus well, and that is the reason why you are not able to see well, and that's the reason why you are producing all the complications. You should know where your anterior capsule is, you should know where your posterior capsule is, you should know where your zonule or the equator is. And if you want to do that, you need to make sure that the pupil is well dilated as well. So that's again very, very important. You can see how easily it goes off. Yeah, once you remove the nucleus, you can remove 1 or 2 iris hooks. But the problem with the iris hooks is that it's really fantastic. It's very easy. Only thing is you need to make 4 ports, but don't keep the iris hooks for too long and have too much of traction. Once you remove the nucleus, you don't have much role for these iris hooks. You can just relax it a little bit, or even remove 1 or 2 iris hooks for that matter, because in cortical aspiration, lens implantation, you don't require that much as well. So, size of the pupil is relative, surgeon's technique and skill, iris tissue properties, intraoperative situation, and all this. You can see here how I'm trying to do a rhexis beyond the margin of the pupil. How do you do that? You can it's preferably to use Utrata forceps or a micro Utrata forceps, but you can do with the needle as well. You can go underneath the iris and go all round, and that is very, very important. Okay, and rhexis under the pupillate margin is very, very important when you are using. And you can sometimes you can get away for the grade 3 cataract. You can get away with pupils like this without any iris expansion. You can by following the protocols which I mentioned. So it's critical when red reflex is insufficient, allows proper, because this is very important. Again, the trypan blue is very important because you need to stain the anterior capsule, because you don't want the what you call the visualization of the to be hampered, of the anterior capsule to be hampered, especially when you are doing the chopping techniques, which is again very important. Adequate hydrodissection and zonule weakness can sing. In chopping technique, I use the karate chop or the anterior chop, use the cold phaco technology, which is available in all the micro pulse or the hyper pulse. If you are going to use the Ozil and the Alcon, Centurion, and the Infinity mission, or the ellipse on the signature, the J&J mission as well, the Signature Pro mission. You can see how it's easy for you to go ahead. I'm sorry, and these are cataracts. The mid-dilated pupil, you can manage fairly well. Only thing is you need to make sure that your rhexis is slightly larger than the pupil size, and do the anterior chop technique. Use a sharp chopper. The Mohan Rajan chopper is available with Appasamy. It's a 1.75 millimeter chopper. I would recommend for the brown cataracts, and 2 millimeter chopper I recommend for the black cataracts as well. So poor visibility, fibrotic or anterior fragile anterior capsules, large lens size, adherent cortical capsular connections, thin or deficient epinucleus, tenacious leathery lens fibers, thin posterior capsule. All these are challenges when you have small pupils with hard cataracts. Challenges with small pupils and hard cataracts can be overcome with proper mental preparation. and you need to plan these patients. You have a plan A, plan B, plan C, and you need to talk to the patients adequately, because there can be zonal problem which you don't know because the pupil is not dilating. So this is just to give an idea about the small pupils. I would since Sujata, this is actually Sujata's talk, because she is not well. I'm presenting this topic, and we go on to the next speaker, none other than Dr. Nivian Madhivanan from MNI Hospital, Chennai, and he's going to talk to us on phaco in mature, that is white cataracts, hypermature cataract. It's here. It's here or that? That's it. Okay, and we can take the questions at the end of the sessions.
Thank you, sir. So I'm Dr. Nivian from MNI Hospital, Chennai, and I'm going to talk about phaco in white cataracts. As you all know, white cataracts pose a challenge for all cataract surgeons. That is the first challenge. And second, it is very difficult to talk after Mohan Rajan sir, because he's already explained and shown how beautifully chopping can be done and how easily it is done. So I'm just going to show some tips and tricks about managing these white cataracts and different types of white cataracts. So this particular one is a slight intumescent cataract. As the sir has already summarized, that staining is very important. Whenever you don't have a good red reflex, don't hesitate to stain, because getting a good rexis is one of the key things for any phaco surgery. Good amount of viscoelastic fill, because you have to flatten the chamber. As you could see in his videos, he put the soft shell technique so that you make sure that the anterior capsule is always flat. So this is one of the techniques I do in these intumescent cataracts, is the fine needle aspiration. So just poke a 30 gauge needle and then aspirate those liquefied cortex, because you can see those liquefied cortex being aspirated. So once that happens, the intralenticular pressure decreases. So now this cataract behaves just like a normal white cataract. So it is easier to do the rexis. And the third thing is doing the rexis after initiating the flap. Throughout the procedure, make sure the triangle shape you can see and the flap is always facing downwards. It is only when the flap lifts up, the tendency is there to extend. And usually during the subincisional area is where it actually extends. So always don't hesitate in these white cataracts, not for all cataracts, to come out always, put in some more viscoelastic, flatten it, push it towards the center, and then continue the rexis. It is not necessary to do the entire thing in a single go. When you do sometimes superiorly, there again the subincisional is where it tends to run. And finally, try to bring the force towards the center and aim for ideally 4.5 to 5 millimeter rexis. So you can use whatever you're comfortable with. Here again, you can see the slight extension going to happen. So the third thing is always stop. When you think there is a doubt of element that is slightly extending, don't try to continue. Stop, analyze, put in viscoelastic, and then the force towards the center, so that you're trying to bring the rexis back and complete the rexis. People who are comfortable with the forceps can also use the forceps. So the cystitome or the forceps, so whatever instrument you are comfortable with in doing the rexis is ideal to do the rexis. So here again, pulling it towards the center to get it back inside. So once the rexis is done, the choice of phaco is either the stop and shop or the direct shop. So this is something like a modified direct shop, wherein you make a burr hole in the superior part. So two things it helps. One, it helps you create a crater. And the second, when you bury your phaco probe inside, you go more into the core of the nucleus. So this helps in the chopping method. And as I said, the vertical chop is more preferred here, because you don't have to go under the capsular margin. And watch for the epinucleus plate cracking. So unless there is a separation of the epinucleus plate in these cases, as you can see that piece, that separation of the pie was there, then you start removing the piece. In these types of harder cataracts, mature cataracts, I always prefer to remove one of the pie of the pieces, because one, you can see that you get more space, so you can actually see, because these are large cataracts. The other, moving them inside the bag also makes it easy. And you all know most of these cases, you're not going to have a lot of cortical fibers, just some remnants. So either you can put the lens and also aspirate the cortex that is there in the periphery. And usually these are all these 6 sticky cortex, and most of the times the central zone is always clear. I always prefer to put the IOL under irrigation, But again, the trick here is you should make sure all the wounds and the sections are watertight and there is no collapse of the antechamber. So why a good resist? As you can see, the overlap of the capsular margin. So PCO prevention is not only about the type of IOL, it is about the surgery also, how you get the good overlap, so that all the benefits of the IOL are made use to lessen the posterior capsular opacification. So these white cataracts, so this was a simple white cataracts where it is actually softer and not very hard. So sometimes you see white cataracts like this, but you can see that underlying brown component there. So you know these cataracts are a little more harder, so this technique is not going to work. They are not the intumescent cataract. It is just in the stage of going into hypermature, and you can see slightly being mobile. So here again, after staining, again the rexis. So in all cases, rexis is the key here. Why slightly smaller rexis is because in case you have a rupture or something goes wrong, you can always keep the lens in the sulcus or have an optic capture. So rexis is very, very important. Here again, burying it into the core of the nucleus and initiating the chop. As I told from the first case, this is a slightly harder case. As you can see, the crack did not go through. So I'm not doing it in the same place. I'm rotating it. I'm trying in a different plane, isn't it? So again, going for the crack. So unless you get the crack and separation of the piece, don't try to pull the nucleus out, because that time you see the hemisphere of the nucleus coming out and the whole bag, there's become stress on the zonules. So once you have this separation that happens, then remove the piece outside, because once you get that, then it is just like doing any other normal phacoemulsification. Keep topping it up with viscoelastic in the initial stages, because you are using more phaco energy than in the normal cases. So don't hesitate to come out, put in viscoelastic and go back and complete the cases. Then there is no particular method. Again, the comfort of the surgeon. So you can do a stop and chop method also in these hard cataracts. So it looked white here again, but once we removed the component, it was actually a very brown cataract underlying here. So here I'm doing a normal trenching method in phaco 1. Yes, just use little more phaco energy than you usually do. So this is again a modified stop and chop, where after doing the trenches, because the central place is where the thickness of the nucleus is the maximum, so that is where it is difficult to crack. So now once you have this trench in the center, you can go to the periphery there and hold it, and then the cracking becomes slightly easier because you're separating only that area. And center, since you have a trench there, the plate is thinner and it easily cracks. So this is another technique where you can do a modified stop and chop technique, and this is the other side, just rotating it and see the crack happening. See, once you see that line dividing, and then you have almost completed 50% of the surgery here. So yeah. So just by following the basic principles of phacoemulsification, using the right power of the machine, don't be hesitant to slightly increase the power, because sometimes we are stuck to the same parameters in the machine, and that is when we start pushing the nucleus. When you push the nucleus, then the zonules, which are already weak in these cases, break, and then we land up into problems. So there is no harm in increasing the power in such when you deal with these hard cataracts, isn't it? So here again, at the end of the case, you can get very good clear corneas. So then the last type of white cataracts will be when you have a hypermature cataract like this with a leaking proteinaceous material with the phacolytic glaucoma. So here again, it was planned for phacoemulsification. So here also we have a mid-dilated pupil. You can see the PXF in the margin, and again this liquefied cortical material that is coming out, which is being washed. You can either use the Simcoe cannula also. Here, why I'm using the forceps is you only have a small nucleus in these cases. So you won't have a grip when you do with a cystitome. So that is why in these cases, forceps is actually a preferred choice, and it is easier to do with the forceps. And this I'm doing a new technique called the IOL scaffold technique. And this can be done only in cases where you have a small hypermature cataract, because these cataracts are very hard and they keep moving into the bag. So it's very difficult to crack it, one, and then two, the bag is also weak. So sometimes when you see the end of the surgery, the whole bag crumples and comes out of it, isn't it? So what I'm doing here is injecting the foldable lens underneath the hypermature cataract into the bag. So again, here visualization is very important. Yes, I did not use the hooks in this particular case, and you can see then just making sure I dial the lens into the bag, the capsular margin seen there, and then chopping has to be done in the center, because anytime if you catch the iris in these cases, then the whole surgery becomes messy and it becomes very difficult. So stick to chopping only in the central area. And here again, the IOL acts in two ways. One, when it goes into the bag, it stretches the bag. So it almost acts like a CTR and keeps the zonules up here. And then it also acts like a scaffold. So it prevents any PCR happening in these types of cases. The only thing is phacoemulsification should be done slowly. Don't waste the phaco power unnecessarily because you're doing it slightly above the bag, isn't it? And keep topping it up with viscoelastic. So once this is done in these types of cases, definitely there is no cortex because most of the cortex is liquefied. This is just to show the IOL inside the bag and a safe phacoemulsification being performed. Here again, I would like to highlight this can be done only in cases when you have a small, hard, hypermature cataract. So thank you once again, and big thanks to AOS and Dr. Mohan Rajan sir. And before I finish, I cannot stop without saying there is another technique called the punchorexis. So that is another method invented by Dr. Mohan Rajan and has won many awards. So in these types of intumescent cataracts, you go with the bevel down in a burst mode. So here again, what happens is the burst of energy not only decompresses the anterior part of the lens, but also because of that energy, the pushes the fluid from behind the lens, and the same probe can be used to aspirate. So this is another method which is very useful in doing in cases of intumescent cataract, but there is a slight learning curve, but I think everybody should try it and do it to get the rexis in these types of hard intumescent cataracts. The other thing is the tip. Initially, these were my cases, and I learned most of my phaco from Dr. Mohan Rajan only. So you see the tip is very small. So that means what happens when you're doing chopping, it doesn't bury inside. Can you see that? So most of the time when you're chopping, it keeps slipping away. So that is something we find in it. So he saw my videos and told me that the phaco probe, if you see in his videos, it's slightly longer. So you get more burying, and when the burying is good, the chopping happens even better. The third thing, in these types of hard cataracts, you get what is called a chatter because there can be blockage of the thing. So we should be able to recognize this so that we don't waste a lot of phaco energy. You can see here the repulsion of the hard cataract, which is all going on well. So once the piece ripples, there is something to do with the tubing system. So always stop, reanalyze if there's any block, do a priming of the machine, and then once you see the good followability. So in these types of cases, you should pay attention to whether what is happening because the amount of phaco energy you want clear corneals. As in this case, it was a multifocal. You want clear corneals, and the patient's expectations are very high. The other common mistake here is architecture of the wound. See, once you have a bad wound architecture, in these cases, it is going to be a big trouble because you got the iris coming out of the wound, leakage of the wound. Once the wound starts leaking, the AC shallows. So because the AC shallows, you are not able to have a good followability or chamber stability. So one problem leads to the other here. You can see the chopping is not happening and they're putting too much of stress on the zonules, as you can see here. This is again because of the shallowing of the antechamber, because of the wrong wound construction, and at last you see the zonules all breaking, and this is what is going to happen in these types of hard cataracts. So I think proper preoperative planning, assessment, keeping the right instrumentations, making sure you have the hooks, you have the rings, you have the CTRs in place is what is going to help us in these types of challenging cataracts. So I think Dr. Mohan Rajan again showed the same one of these videos in the hard cataracts. Again, I'm just doing a burr hole there. So this also helps in debulking the nucleus and getting a good purchase. And the last point I like to highlight is you don't have to get a crack in the first go itself. So what happens is there is a crack here, but this is not gone 100%. So don't be in a hurry. So you have to do what is called like a multi-layer cracking till you reach the epinucleus plate. So you have go deeper, stay there, deeper. So your second instrument goes deeper and deeper, and then till you get the crack of the epinucleus plate. So this is like a multi-layer cracking till you have the separation. So once you have the separation, but you can see the movements are all within the bag. There is no too much of stress on the zonules. And then one piece I always prefer to remove, as I've said before, because it gives you some space in these types of hard, bulky cataracts. And this is how the case ends up. So once again, thank you. Thank you, sir, for having me in your session. Thank you.
Wonderful talk, Nivian, as usual. Lovely videos. I think the important messages what you are given is the vertical chopping with a sharp chopper, very important. Bury the tip, expose the tip, create a good vacuum seal, and go vertically down. Okay, don't go normally in divide and conquer. What you do is you go parallel to the capsular rexus margin. Here you need to go vertically down so that you are inside the nucleus nicely, and then you can chop, making sure that you you separate the posterior nuclear plate. And all the pearls have been beautifully enumerated. Then we go on to Dr. Nitin. He's going to talk to us on a very, very important, complicated topic, actually. is a management of a hard cataract. At the same time, it's a subluxated cataract. So you have in double trouble in this, just like small pupils and hard cataracts. And none other than Dr. Nitin can do justice for this topic.
Thank you, Dr. Mohan Rajan. Right at the outset, I would like to thank AIOS for this lovely course which they have had here. And thanks to Dr. Sujata for having invited me to be a part of this course. I have no financial interest. Now, in any subluxated cataract, it's important to understand the degree of subluxation. So you could have a mild subluxation, which is about 25 up to 25%, where the lens edge covers the uncovers the dilated pupil. 25 to 50% in cases of a moderate subluxation, and in case of severe subluxation, the lens edge covers more than 50% of the dilated pupil. Again, like in all complicated cases or all simple cases, a thorough clinical examination is very important. One needs to know the history of whether it's a pediatric case, whether the patient has got signs of Marfan's. Again, one needs to assess the degree of zonular loss. So the zonular loss could be due to focal trauma or congenital defects. It could be an extensive zonular loss in cases of Marfan and pseudoexfoliation. And it's important again to mention here that one needs to see the edge of the lens which has been subluxated. So if it is a flat edge, it just means that the remaining zonular fibers would be strong and healthy, as opposed to a round edge where the adjacent zonular fibers may not have sufficient strength. Preoperative signs of zonular loss one should know in the form of phacodonesis, iridodonesis, or maybe even having vitreous prolapse in the anterior chamber and raised intraocular pressures. In intraoperative signs of zonular loss, the first and the foremost thing one would note are the radial folds while puncturing the anterior capsule during capsular excess. Again, the difficulty in rotating the nucleus is a very, very important sign. Even after a thorough hydrodissection, we'll find that the nucleus doesn't rotate so easily. One should not force the rotation in these cases, because if you try and force the rotation in these cases, you could further cause the zonular dialysis. Again, there could be vitreous prolapse, which is already existing in the AC. So again, that could be due to the zonular dialysis. Now, coming to the capsular excess in cases of a subluxated cataract, the capsular excess is usually difficult because there is a loss of countertraction. You can do a capsular excess with a cystitome, or you need sometimes to use two 30-number needles to use a cross-sword capsule pinch technique. Trypan blue used in these cases is very important. It helps basically to reduce the elasticity of these tough capsules, aids in visualization. However, it's important to point out that the trypan blue can go behind the lens and therefore cause a lack of visualization of the red reflex. And therefore, it's ideal in these cases to paint the anterior capsule with trypan blue under the cover of a viscoelastic. Now, one can, in order to stabilize the bag during capsular excess in cases of large zonular dialysis, one can use capsular hooks, or one can use any instrument like a Krugen's hook to support the capsule. At the same time, it's important to center the rhexis not on the pupil, but to center the rhexis on the lens. Again, sometimes we may have to make an irregular rhexis, like an oval or a D-shaped rhexis, because you need to keep a 2 millimeter gap at least between the equator and the capsular rhexis margin. Flax can be used in mild to moderate subluxation, whereas in severe subluxation, this should be avoided. It is important that the bag be stabilized during phacoemulsification. For a moderate zonular loss, you can use capsular hooks or an anchor, whatever one is comfortable with, or one can use a CTR. The main disadvantage of a CTR is that it prevents the rotation. It makes the lens rotation difficult, and aspiration of the cortical matter also becomes difficult. So the dictum here is, place the CTR as late as you can, but as soon as you must. That is very, very important. Don't delay in keeping the CTR within the bag. In order to stabilize the bag after having the cataract out, if it is a small zonular dialysis, one can use a CTR ring less than 4 hours. From 4 to 9 clock hours, one needs to use a CTR with a CTS or a CONE combined ring. And more than 9 clock hours, one can use a scleral fixated lens or an iris claw lens. I've been using a few lenses which Dr. Nivian has so well made, which makes the scleral fixation of these lenses very, very easy. Now, in phacoemulsification, ideally in a hard cataract should be done within the bag. It prevents the likelihood of the damage to the it prevents the likelihood of the nuclear fragments going behind and but there is a lot of chances of damage to the bag or zonule, so one needs to pay particular attention to where the fragments are and where your tip is. In case of a soft dislocated or subluxated cataract, one can emulsify it into the anterior chamber. Again, cortical aspiration should be done close to the rexus margin, and you strip from the rexus margin towards the periphery in order to decrease the strain. Tangential stripping in areas of missing or weakened zonules limits the stress on the adjacent fibers. One can use either a 3-piece IOL in cases of a well-centered capsular bag. If the capsular bag is not properly stable, one can think of a scleral fixated or an iris fixated IOL. I'll now show some of these techniques in my videos. So this was a subluxated hard brown cataract, which was a traumatic cataract. And you can see it's almost about 3.5 hours of subluxation. We start off by doing a rexis here. Again, if you can note over there, the edge of the lens over here is flat. So that just goes to prove that the adjacent zonules are not weak. So one can complete this rexis even without supporting the bag, because there was no real movement of the bag which was occurring during the rexis. A good hydrodissection is very, very paramount. Having done this, one needs to initially debulk the anterior epinucleus from these cases, because unless you debulk the anterior epinucleus, it will be difficult to insert your CTR ring. Again, every time you're coming out with the phaco probe, it's very important not to suddenly come out, but to inject viscoelastic, reform the bag, and then only come out from your, lift your leg from the irrigation. We now go ahead by inserting the CTR ring. Again, this is a large eye, so we are using a 13.5 millimeter CTR ring. Inject it away from the area of the dialysis, and then dial it towards the area of the dialysis. Using a bimanual technique, 2 instruments is very important. One needs to be sure that the CTR ring has gone into the bag and one edge is not in the sulcus. And then one can go ahead with emulsifying these cataracts like in any other hard cataract, like Dr. Mohan Rajan had initially shown and Dr. Nivian also so well demonstrated. The steps remain the same. It's important to work in the center. Do not go into the periphery. Normally in these cases, I wouldn't do a tangential chop like Dr. Mohan Rajan demonstrated. A vertical chop works beautifully in these cases. One needs to be patient to chop each piece. Again, it's at times in these hard cataracts, as you keep chopping, it is better to get a few fragments out. So that what happens is you have enough space for the nucleus to rotate, because you don't want to forcibly rotate these nuclei. So as you keep chopping, it's better to get individual fragments out instead of waiting for a chop of all the fragments like we normally do in a normal case. So you see, most of the fragments are being chopped and aspirated within the bag. There a few fragments do come out, so one needs to keep filling the chamber with a good viscoelastic. And all through, the CTR has kept the bag intact. So you see that there is no movement of the bag. There is no sudden increase in the depth of the chamber to suggest that further zonules are also being damaged. So one needs to keep a close attention at the rexus margin all through during the surgery, because if you see the rexus margin suddenly coming towards the center from the opposite edge, there are high chances that you have destroyed the zonules in that area, and therefore the bag is getting subluxated even from that area. So the remaining phacoemulsification goes on, the aspiration, once all the nuclear fragments are chopped. I'll go a little bit fast. So the cortex is then removed. In these hard brown cataracts, there's hardly any cortex. Again, stripping of the cortex has to be done very, very carefully in areas of the zonular dialysis. And then a single piece IOL can be inserted in the bag. In these cases, the CTR ring has kept the bag stable, so we didn't feel the need of putting in a CTS segment over here. The wound is hydrated. This is the end of the surgery. And these are the pictures 1 day post-op. So there was a corneal opacity which was already there because it was a traumatic cataract. My next case is, it's not a hard cataract, but would like to point out a few steps. The steps would remain the same. This is a subluxated cataract with vitreous already pre-existing in the anterior chamber. So here we need to first get the vitreous out, and the ideal way would be to go from the pars plana so that you don't pull the vitreous anteriorly even more. So you're debulking the vitreous in the area of the zonular dialysis. So we're doing a 23 gauge vitrectomy only in the area of the loss of the zonules. Again, here you see that it's a large area of zonular dialysis as compared to the previous case. Started the rhexis with a cystotome, and then we're completing it with a utrata forceps. Again, since there is no counter traction at this stage, I decide to put in 2 capsular hooks. Now here, this was a soft cataract, so we're trying to, while hydrodissection, trying to get the nucleus out, and then it is very easy to emulsify this lens. And since in a very soft cataract, this could even have been aspirated, but in a hard cataract, one would need to follow the steps as shown in the previous case. And here we are aspirating out the fragments. Now, since it's a large area of zonular dialysis, we are putting in a CTR ring with a CTS segment. So that is the ring being injected with an injector. And then a CTS segment is sutured. The bag is stabilized with a scleral tunnel incision. Railroading of the sutures are being done here, so that the knot in the sclera lies in the scleral tunnel itself. Again, once you need to see the amount of tightening so that the bag is not flax, and then the anterior vitreous which is there in the chamber now is got out, and a single piece IOL is inserted into the bag. My next case is a case of a subluxated cataract in a patient with Marfan's, a young patient here. Again, not a very hard cataract, but to show a few principles. This is an area of a very large subluxation. So we start by making a Hoffman's pocket over here to stabilize the CTS segment, stabilize the bag with the CTS segment. We are starting with 4 incisions. Fill the chamber with a viscoelastic. And now we start, this is the cross sew technique. So these are 2 30-number needles. They are used as a cross sew technique to initiate the rhexis. And once the rhexis is initiated, you can try and complete it. Here again, while completing it, you saw that there was the movement of the whole nucleus. So we are using a Krugen's hook to act as an artificial zonule or to give counter traction in the area of the dialysis. And then you can complete the rhexis. Again, you can see the rhexis being centered on the lens itself. You can't center it on the pupil. Having completed the rhexis, one needs to do a thorough hydrodissection, because it's hydro and visco dissection, because otherwise you would not have space to insert the capsular hooks. So we are putting in 2 capsular hooks in the area of the dialysis. Just speeden that up a little bit. So the capsular hooks are inserted, and now again, being a soft cataract, we're just doing a bimanual and getting the lens matter out. It was a young patient with Marfan's. The reason why I'm showing it, in spite of the fact that it is not a hard cataract, and the course I know is of a hard cataract, the principles remain the same. So now you see that it's a well-centered bag due to the capsular hooks. So we now again put in a CTR, a Sioni CTR with a CTS segment. So we are passing a suture, a 90 proline, The CTS segment is then being inserted into the bag. It's important that the segment is now rotated and brought in the area of the maximum zonular dialysis in order to give a support over there. So one needs to see that it is exactly in the area of the maximum dialysis. And now you can use the same railroading technique. Only thing is here we have not made a scleral tunnel. We made a Hoffman's pocket. So the needle would start above through the sclera transconjunctivally above the area of the Hoffman's pocket, so that at the end of the suturing one can get the sutures out. Again, it's important after having inserted the CTS segment to do a thorough vitrectomy in these cases. Again, I would prefer a pars plana vitrectomy. Here you can see these sutures being drawn out with a hook through the Hoffman's pocket so that the knot is not exposed. So that was the end of that surgery. Again, it's a difficult case in hard cataracts, but the point is it can be done. Now, my last case, I would like to show that in cases where you cannot do a phacoemulsification, it is possible to do a SICS also with a hard brown cataract. So this is a subluxated hard brown cataract. You can see the area of the subluxation in the superior quadrant. It's about 3 to 4 clock hours, rather 2 to 3 clock hours in the superior quadrant. It's important in these cases to start operating on the side, from the side of the area of the subluxation, so that the subluxated area is, you're facing the subluxated area and not on the opposite side. The steps for the SICS are the same like all of your eminent surgeons have been doing. You make a proper tunnel. A large tunnel in these cases would be better. Enter the chamber, do a rhexis. Now, having done the rhexis, the next step is to make relaxing incisions in the rhexis, because this relaxing incision is very important. We don't want to cause too much stress on the bag while trying to anteriorize the nucleus. So inject viscoelastic behind the nucleus and do a visco as well as a hydrodissection at the same time to try and dial the nucleus into the anterior chamber. Again, moment the nucleus is out, fill in the bag with more viscoelastic, because you don't want, and to check whether there is any further zonular dialysis. We are now putting in a CTR ring. Again, like I said, the CTR ring should always go from the side of the intact zonules and then rotate it towards the side where the zonules are absent. And now there was a slight extension, so we are just completing that rhexis in the area of the extension. The cortex which is in the bag is now aspirated. Again, you see that it is important that in the area of the dialysis, one has to be very careful while aspirating the cortex, otherwise you would increase the amount of the dialysis, and then you put in the lens in the bag. Again, while dialing the lens in these cases, one has to be again careful that you do not increase the dialysis. And that would be the end of the surgery. So thank you for your kind attention. So the basic thing is the steps are important. One needs to follow an algorithm. One needs to see the degree of zonular dialysis and how hard the cataract is, and follow each and every principle which is there. The principles are not only for the subluxated cataracts, but general principles of treating any case, any hard cataract with a phacoemulsification. Thank you for your kind attention.
Very beautiful talk, Nitin. Very nicely covered, because it's a very tough topic as well. So the take-home message from Nitin is very simple and straightforward. That is, you need to have a circumferential support for the lens, and you also need to have a radial support. The circumferential support is given by the CTR. The radial support is given by the capsular hooks or the iris. Sometimes you can use iris hooks as well. Only thing is, please understand that the capsular hooks rest on the equator and doesn't produce any stress on the capsular rhexis margin, whereas iris hooks can cut the capsular rhexis margin. You need to be a little careful about it. So, but if you don't have access to capsular hooks, you can use iris hooks as well. In the beginning, you can have this thing and you can put the CTR a little later. We'll discuss that probably when we have time after my talk, the final talk. That'll be on this thing. Then we can discuss. We can take some questions from the audience as well. Yeah. So what we have tried to what you call cover in this important course is how there are many ways to skin the cat, and what are the different ways we have shown that how to manage a mature hard brown cataract, and then how to do small pupil and hard cataracts, and how to do a subluxated hard cataracts as well. Now we come to the final, that is the flax in hard brown cataracts. There is femto laser assisted cataract surgery in hard brown cataracts. These are my financial interests. So you need to combine the technology with the technique. The technology is available with you in the form of various machines like Stellaris or whatever Centurion, whatever the machines are. All the machines are equally good. The keys to the refractive cataract surgery is increased refractive accuracy, decreased complications like corneal edema and posterior capsule rupture, choose the best quality visual quality IOLs, and exceed the patient expectations. You know how the artificial intelligence is taking us by storm, and in the form of in the diagnosis of diabetic retinopathy, glaucoma, and various other conditions as well. Can a computer perform better than a human brain? Obviously, it can do because the precision is much better. And we have different what you call the flax systems, the Catalyst, the Lensex, and the Lens AR, the Victors. Now the Zemer is also there. And just to show you the difference between a manual phaco and the flax, the manual phaco is similar to Sachin Tendulkar. Okay, Sachin Tendulkar is good only in one what you call aspect of cricket, one format of cricket. Whereas Dhoni, as you all know, is very good in T20. He is very good in one day international, very good in test as well. So that is the versatility of Dhoni. So when compared to Sachin, Sachin is also a great guy. So Manuel Feko is also very good. But flax is something which is better because you have all the advantages. Like doing the incision, you can do the incision main port, side port, unless you have a dense Arcusin list. You can do the LRI, which is actually very predictable. Less than one diopter, I do the LRIs. Perfect rexis, nucleus liquefaction. You can work in complex situations like white cataract, brown black cataract, subluxated cataract, and all these this thing. So the fragmentation settings, I think it's beyond the scope of the lecture. But how many of you are using flax? Any of you are using? I'm using the Catalyst machine. Any of you are using that? No. Okay. Anyway, whatever it is, it's going to become the future because as the companies are going to reduce the cost as well, and it's going to be more affordable to everybody, and this is going to be the probably the way to go. You have the soft quadrants, you have different things. All these are what you call pre-programmed in this in the flax machine, in the femto catalyst machine. Vertical spacing, the grid spacing, the horizontal spacing, the medium cataracts are also there. The hard cataracts are also there. The vertical spacing, the grid spacing, the pulse energy. All these are the rock hard cataracts. They all just like you put your parameters for your phaco, you can put all these parameters in this thing automatically when it shows when you put it as a rock hard cataract or the hard cataract. All these parameters come into play. Just to show you the different this thing, wherein the quadrants in a medium cataract you can go for 4 quadrants. In a hard cataract, I go for the 8 quadrants or the octants. These are called the 4 quadrants. Then they have the sextants or the 6 quadrants, which is again very very important. So these are the brown cataract. You can see here these are brown cataract. This is what we are talking about in this particular course. It's like a piece of granite inside the eye, and you can see seeing how big the cataract is. It's nucleus and more nucleus, no epinucleus, not much cortex as well. What is the challenge? The challenge is difficulty to crack the nucleus because of the leathery posterior nuclear plate, thin posterior capsule, large nucleus, poor or no cortical cushion, increased incidence of corneal edema and postoperative corneal decompensation, and increase in the PCR. So if you do the conventional divide and conquer and stop and chop, you can end up in using a lot of what you call phaco energy, and you can have a corneal burn. And like this, you know the consequences of a corneal burn, like irregular astigmatism, wound infection, intraocular infection, inflammation, wound gaping, and all these problems occur. You can have a corneal edema like this, for example, after a manual phaco, you can have in a brown cataract if you don't follow the proper parameters, but the protocols. So the corneal edema may clear up in about a month. Sometimes it may clear up in about 6 to 8 weeks time with the use of hypersol. But sometimes, many of the times, the corneal edema can be associated with cystoid macular edema because a lot of inflammatory cytokines are released into the eye, a lot of prostaglandins when there's a corneal edema, or you can even have something like a TAS or a fibrin reaction on the lens. When you have a femtophaco, these consistently you can deliver clear corneas and the pristine wounds as well. You can see the clear corneas day one, and that is the advantage. Just to show you one brown, it's actually a cataract on nigra. It's a black cataract. You can see here. I'm doing a manual, phacoemulsification. I'm doing a big trench, and every time I bury, this is a vertical chop technique, and I'm using my sharp chopper, which is about 2 millimeter. As I told you, it's a Mohan Rajan chopper available with Appaswamy, and normally I use 1.75, but cataracts like this I use 2 millimeter, and the advantage is that it opens up the posterior nuclear plate. You can see how many times I need to bury, and every time I bury, I need to give phaco energy. So this to show you the difference between a thing. Of course, it is doable, and it is we know if you follow the parameters. Now and then you need to put viscoat into the anterior chamber, making sure that you separate that nucleus all the way. You can see here how it is. It's almost like a black cataract. You can see here how the cataract nigra is there, and these cataracts are very huge cataracts, very thick cataracts, and the zonules are also a little weak. You need to be careful, and you have to be a little careful about lateral separation, bringing it up and making sure that you sing and not much chatter, not movement of the nucleus. So again, these are the parameters I use on a sterilized mission. Just to show you one similar case, a brown black cataract, you can see here. The rexis is already done. The pre-chop is already done. I just need to go in, and you can see here I'm chopping that. You can see very fact that the gas bubbles are coming from behind. It shows that the chop has gone all the way into the posterior nuclear plate. I just have to bury that using a very, very minimal phaco thing. But apart from that, the chopping is becoming very, very easy. And because I already chopped and the rexis is also beautifully done, and it makes the life very, very easy. And once I chop, because once I separate the nucleus into smaller pieces, then the rest of the phacoemulsification is like a child's play for you. So just to show you another patient, you can see here how the cataract. I'm using the femto laser assisted cataract surgery. The parameters are there for all of you to see. And again, just to show you that the different parameters. This is a white cataract. Many people think that the catalyst will not be able to penetrate. Don't underestimate the versatility of this catalyst or the flax missions. It can, as long as the OCT is able to recognize. You can see this is a white cataract, and many times, if you do the white cataract capsulorhexis, you end up in Argentina flax sign. You can see the pre-cuts are already there. The chopping is already there. I need to go in and separate that in the cleavage planes, which are already there with the chopper. And sometimes I can use only a Sinskey hook, and that opens up the posterior nuclear plate because already it's cut, and you can even soften the nucleus also. So it makes the life easy, not much phaco power, and the amount of the phaco energy is very, very less in this case. Just to show you another patient with a grade 3, grade 4 cataract, I'm just showing you again, rexis is done already, free floating rexis most of the times, 99% of the time, and you can see here, I'm just using a Sinskey hook and just burying that, just to show you that because of the pre-cut is already there, pre-chop is already there, the femto, the liquefaction is already there, the cutting is already there with the femto laser. It's easier for you to separate the nucleus and you can go ahead with the surgery. And these are octans. Sometimes you do six sextants, but I do octans because I want lesser pieces, that is 8 pieces. More pieces, and so that it makes the life easy for us. Just to show you how the another patient, you can see here, I've done the main incision, I've done the side port incision as well. And the advantage of the femto laser assisted incision is truly a triplanar incision. Only thing is the incisions are a little corneal, but if you have dense arcus senilis, probably the incisions will not work. And you can see here how the cataract is quite dense. You can see the pre-chopping has already been done. You can see the cuts into the nucleus. And I need just to go in and bury the phaco. Again, a vertical chopping in right in front of the rexus margin, so you know exactly where your chopper is, and go vertically down like this, and with the phaco probe, as if you are going into the anterior vitreous, not parallel to the capsular rexus margin. Again, I'm chopping that because in the same area where the femto has made the cuts there, and you can see the gas bubbles are getting released. So the very fact the gas bubbles coming up, it shows that the nucleus cut has gone all the way into the posterior nuclear plate. Again, another patient, you can see how beautifully it's there. Just to show you a corneal guttata, the patient has got a very thick cornea and a very brown cataract as well. You can see the pupil is also not very well dilating, and this patient wanted they required a thing. But it makes life easy because already the rexis is done, the pre-chop is done, and a very little amount of phaco energy is used, and I will go ahead and do the cataract surgery without any problem. And it makes life easy for us. I can see the postoperative, despite the cornea being quite sick. You can see the postoperative, the cornea is cleared up in day 1, and day 7 also it's very good. Again, a patient with a subluxated hard cataract. What is shuttlecock injury? The shuttlecock injuries are probably the worst injuries can ever have, and you can see here how the entire nucleus is wobbling around. The rexis is the most important challenge in a subluxated cataract. So the rexis is done. It's a mature cataract, so it has gone through and it has cut. The rexis is already done, and I'm just supporting that area of the zonal weakness. I put the CTR as late as possible because yeah, I don't want the CTR to go and trap the new epinucleus and the cortex there. As long as I was able to support, in this case, the zonal dialysis was only about 3 or 4 clock hours. And can see here, I just have to go and pick up the nucleus because already it stopped there, and I don't give much stress on the bag because already the bag is very weak because of the zonal dialysis, and the rest is very, very easy. And then going ahead, and the end of the surgery, I put the CTR at that time, and then remove the cortex, and then put the CTR and put the MA60 lens. So femtophaco, the advantage is that you can have consistently clear corneas, clear wounds in all these patients, and that is the biggest advantage. Just to show you a patient with again a brown cataract and also white cataract, you can see here Argentina flag sign and type 1 intermittent cataracts. White cataracts, the femto works wonderfully well, and you can get this consistently good rexis and no Argentina flag sign. Only thing is, look for skip areas there. Sometimes it may not be a free floating, sometimes it can be small attachments or micro attachments can there. Again, small pupil hard cataracts, if it's a pupil is less than 5 or 5 point, my cutoff is around 5.5. If it's around 5.5, I go ahead and do the femto, and that is the biggest advantage because already the rexis is there. Another advantage of the catalyst machine, it cuts beyond the rexis margin. So, and it makes the life again very easy. Reduce surgical time, reduce effective phaco time, more precision, clearer corneas, and reduce complications. White cataracts, hard-bound cataracts, posterior polar cataracts, subluxated cataracts, fuchs endothelial dystrophy. Nowadays, we have what is called lot of these in-between cataracts. That is called the NHNT cataracts. What is NHNT? It's neither here nor there. Very difficult to crack these cataracts, crack these or chop these cataracts, or even suck these cataracts. So that is a problem. And the NHNT cataracts also, it works very well. So thank you again, AOS, for this wonderful opportunity. and the patient attention for all the delegates. And I would like to thank my faculty, Dr. Nitin, Nivian, of course, Sujata has not been able to come because she's unwell. So we'll take some questions from the audience, and also we have some more time. I think another 10 minutes is there for us to take some questions. Any questions from the audience regarding this topics? Can you use the mic?
Hello, good morning, sir.
Yeah.
Sir, is there any chance of getting a posterior capsule rupture, and that while doing that chop with femtosecond and it's go little deeper and damage the posterior capsule? Is it?
I'll just come. It's a good question, but what happens is in posterior polar cataracts, I keep the offset. We have an offset from the posterior capsule. So normally we keep it around 500 microns from the posterior capsule. So there's absolutely no chance. It stays exactly 400 or 500 microns from the posterior capsule. Posterior polar cataract, I keep it a little more. Okay? Little more than 900 microns, I keep it. So because I don't want to go near the posterior capsule at all. So there's no chance of the thing. But the chances of the rhexis tear, you have to be very careful. Most of the times it's a free-floating rhexis, but always in a mature cataract, I would like you all to stain the capsule very nicely and then try to make sure, because small attachments can be there. If you just pull the rhexis, and sometimes there can be small tags, and this can extend to the posterior capsule and you can have a posterior capsule rupture.
Sir, size of capsular axis is also manipulating is that machine, sir? Like 6 mm, 5 mm, like that.
No, we in the femto we use around 5 mm or 5.1. Yeah. But normally I would size about 5.5 to 5.25 if you have got hard brown cataracts, if you're doing the manual phaco. If you keep it very small, the problem is you will not have a space there. So because if you keep it around 4 millimeter or 4.5 millimeter, you will not have space for you to chop. So you need a slightly bigger rhexis for these cataracts.
Thank you, sir.
Yeah.
Sir, a very nice presentation, sir. Good morning, sir. I have a question. For this femto-assisted cataract, do you block, or you do in topical also, sir? Or any subconjunctival hemorrhage and all you face when you block, something like that?
No. We do mostly topical. Sometimes the patient does not cooperate. We do subtenons or the parabulbar anesthesia, and we don't normally block these patients. Yeah. Unless the patient is very uncooperative or anything like that, then we do. Very rarely we block. So we can do subtenons very comfortably without any problem at all. Yeah. Or even topical anesthesia is good enough. Only thing is, if you're going to touch the iris, if you've topical anesthesia in small pupils, you need to be a little careful. Now and then probably give intracameral preservative-free xylocaine. Anything you'd like to add?
Like you mentioned, I think in every case of lax in a white cataract, it's important that when you're getting the capsular flap out, you try and rotate it in the direction like you would normally do a rhexis, because like sir mentioned that there could be tags, you would pull upon the zonule. So rotate it like you're doing a rhexis. Don't try to just pull it out. That is, I think, a very, very key point. And again, like someone pointed out in posterior polar cataracts, just because you've done a good rhexis and kept and nuclear softening in a posterior polar doesn't mean that these cases are not still prone to opening up the posterior capsule. But so one has to be very careful of while doing the hydrodelineation and rotating the nucleus, because that is the time when you would get more ruptures in the posterior capsule.
So I have one more question. In white cataract, I have seen some of the videos. If the rhexis is not completed, some of them continue the phaco with the can opener also. Do you advise that, sir? Is it okay?
No, I would not advise. I would not advise can opener in any of these cases. If you're going to do, especially when you have a white cataract with hard brown cataract, there's a possibility of the can opener definitely extending. So because a lot of manipulation is there, it's not like, if you're going to have a softer cataract, then probably you can get away. But any can opener, please understand, it's not good as a rhexis strength wise. So you can't, if you're going to have, depending on the comfort level. So if you're able to, experienced surgeon probably will be able to do it. But the take-home message generally for everybody is, if you have a rhexis which is lost and you're going to have a can opener in that area, especially in the inferior area, there's a possibility of the rexus extending. Yeah. Or even small flaps can also be there. Sometimes there can be small tags. You have to be a little careful, and they can extend during the phacoemulsification across.
Mohan, I had a question for you that in case you need to put in the capsular hooks in cases of a femtorexis after doing a femtorexis, how sturdy will be? Because they say that the femtorexis strength is probably not as good as the strength of a manual rexis or.
The femtorexis, there are a lot of papers now. Femtorexis is as strong as a manual rexis. There's absolutely no problem at all. You can put an iris hook, you can put a capsular hook. In that case, it doesn't extend at all. It's very good. And what I would suggest is for all surgeons is that when you have a subluxated cataract, you support initially with the iris hooks or the capsular hooks in the beginning itself, like what I showed in that particular case, a traumatic cataract, white cataract. So that's the way to go, but no problem at all if you have this thing. But yeah, I hope I answered the question.
Sir, I have one more question. Like for the subluxated cataract also, have you tried this femto-assisted cataract, sir?
Yeah. I showed that, no? That case subluxated cataract. I do femto, unless the gross subluxation when there is a tilt, no? It's very difficult to do. But these are subluxation 3-4 o'clock hours. It's very easy to do a femto because the capsular rexis is the biggest challenge in the subluxated cataract, which is shown by Nitin beautifully. Because there is no peripheral resistance or peripheral this thing for you when you do a capsular rexis, very difficult to do. But when you have a femto, the advantage is the capsular rexis is there, number one. Number two is it is also pre-chopping of the lens. You don't have to manipulate inside the bag for a long time. And also the liquefaction of the nucleus is there, softening of the nucleus is there, everything is there for you. So you just have to pull the capsular rexis out, you just have to do a gentle hydro and then support the area of the zonular dialysis which I have shown there, and go and pick up these cataracts and come out. It will walk into your phaco port without any problem at all. So that is the biggest advantage. I think because the biggest challenge is the subluxated cataract. You try to do a rexis, you will not be able to do a rexis properly unless you have that, especially when you have gross subluxation and all, there should be a peripheral or you need to use bimanual technique which he has shown. You have to support in the case of Marfan syndrome, Nitin has shown that.
Good morning, sir. Sir, I have a question. In the cases when there is a hard cataract along with the gross calcification over the anterior capsule, does the femto-assisted capsular rexis works well? Yeah.
Femto will work well as long as the only thing is you need to increase your energy settings a little. It will cut through the anterior capsule as well, and unless otherwise it is too much in the periphery. If it's in the center, what we can do is we can cover it up. Suppose it's in the center, we can make a rexis of about 5.1, 5.2. That will cover up that entire area of calcified anterior capsule. And sometimes even in the periphery, I've done this femto assisted capsular rexis flax surgery. Works very well. The biggest advantage is that these rexis, even if it's cut there, doesn't extend much. It doesn't extend to the posterior capsule like the regular ones because it's all calcified there. It's all already very fibrosed and calcified. So it doesn't extend to the posterior capsule. So we have done it, and it's a very useful method. If you don't have femto assisted, then probably you can do manual also. Only thing is you need to use some vitreous scissors to cut that area of the capsular rexis, or vitreous scissors, or sometimes even vanas, or you can use that area, this thing where you need to cut that area of the calcified area. So that makes life easy, and you can get away with phacoemulsification in these cases.
Sir, one more
Any
question.
tips, Nitin?
Sorry, sir, one more question, sir. Sir, in the cases of absorbed cataract, when there is not much nuclear support behind the anterior capsule, does the capsular rexis with femto-assisted laser works well? It does not go to the posterior capsule.
No, it doesn't go through the posterior. See, the advantage of the femto is that you can actually limit. It works only about, you can limit the capsular axis only in the capsular axis
Depth.
area. It will work. It will cut only the anterior capsule, just 500 micron below, 500 micron above, or you can even lessen it. You can make it 200 micron, so it doesn't go into the posterior capsule, but doesn't go into the nucleus also. And in Morgagnon cataract, if you have got the advantage is what Nivian showed, you can do the absorbed cataract, you can do the IOL scaffold, because these capsular bags are very lax, very loose as well. So sometimes the nucleus will keep on moving around in the capsular bag. You don't have seeing. You bring it up and put an IOL into the bag and then go ahead with the phacoemulsification. Only thing is making sure that you don't do the phaco in the anterior chamber, making sure that you're doing the phaco in the pupillary area or in the iris plane, and making sure that you have a good dispersive viscoelastic like viscoat to protect the corneal endothelium.
Thank you so much.
Yeah.
Thank you.
Okay. Any more questions? Thank you very much for the all the questions and the good interaction. I would like to once again thank the faculty, Nitin and Nivian, and for this, and also the scientific committee of AIOS for giving this wonderful opportunity of doing this course again.